Hello everyone. Today I will be presenting my change quality management project on patient safety preventing falls in skilled nursing facilities using the Plan, Do, Study, Act model for quality management. Plan, issue identification. Falls are a quality standard that affect residents in skilled nursing facilities. According to the Joint Commission, falls resulting in injury are a prevalent patient safety problem. They're one of the top 10 sentinel events reported to Joint Commission, with 63% resulting in death. Average cost for fall with injury is about $14,000. Further analysis of their database revealed that common causes of falls are inadequate assessment, communication failures, lack of adherence to protocols and safety practices, inadequate staff orientation, supervision, staffing levels or skill mix, deficiencies in the physical environment, and lack of leadership. According to the Agency for Healthcare Research and Quality, fall ranges from 1.7 to 25 falls per 1,000 patient days. According to the CDC, 1 out of 4 older people falls each year, with 2.8 million treated in the ED and over 800,000 a year are hospitalized. In October 2008, Medicare and other third-party payers stopped reimbursing hospitals for treatment of falls, which are preventable. I conducted this project at a skilled nursing facility where I worked, and this was done under Unit 3. Here is the facility profile and statistics. It is a 149 bed capacity, composed of 100 short stay patients and 49 long-term patients. Unit 3 has 59 patients. Short stay patients for rehabilitation stay with 11 to 14 days length of stay, while long-term patients are permanent residents of the facility. Number of employees in the facility is 205 with nursing, physical, occupational, and speech therapy department, case management, social services, dietary, and activities. Patient to CNA ratio varies from 1 to 8 for day shift and PM shift, and 1 to 17 on night shift. RN to LVN patient ratio ranges from 1 to 14 to 1 to 25. I studied the incidence of falls of the facility. Review of the quality assurance and performance improvement records indicated that the facility was having 10 to 15 falls a month on Unit 3. Falls with serious injuries like fractures for the year 2017 was 5, which resulted in hospitalization. Falls with minor injuries like skin tear, abrasion, bruise, or sprain range from 5 to 10 a month. Quality variance. When we are analyzing a problem, it's important to analyze evidence to quality variance in contrast to the expected performance standard. According to the CDC, 1,800 residents in nursing homes die each year from falls. There is an increase of falls where 10% to 20% of falls cause serious injuries and fractures. Falls result in disability, functional decline, and reduced quality of life. Based on the incident log of the facility, falls occur on 20% of the patient population a month. 10% of these falls are with minor injuries like skin tears, abrasions, hematoma, and bruises. Expected performance standard. Nursing Care Center National Patient Safety Goals number 9 states that to reduce the risk for patient and resident harm resulting from falls. According to the Joint Commission also, assessing patient and resident risk for fall is very important. Educating staff on fall reduction program in timeframes determined by the organization, educating patient, resident, and their family for any individualized fall reduction strategies, and evaluating effectiveness of all fall reduction activities. The facility's objective is to reduce falls by 50% that is equal to 5 falls a month on Unit 3. Root cause analysis. Part of the plan phase is also to have a complex grasp of the problem, as evidenced by a thorough root cause analysis. Here is a graph that illustrates the different causes why patients were falling. 33% were due to toileting issues, 29% were due to getting out of bed, 14% were due to patients who were disoriented post-admission, and 24% were due to behavioral issues. This is a table also which describes the number of falls on the different nursing units for the last quarter. For Unit 1, there was a total of 26 patients. Unit 2, a total of 21 patients. And Unit 3, total of 33 patients. So Unit 3 is where most of the falls happen. Other reasons for falling also include staff lacking engagement in safety awareness, staff lacking education on fall prevention strategies, falls occurring during the first 72 hours after admission, staff's lack of knowledge to manage patients with behavioral issues, staff not anticipating toileting needs, and insufficient staffing on Unit 3. Scope of the problem. It is important to note the scope of the problem, including all stakeholders in the process under consideration. Review of the CMS CASPER report on the facility level quality measure revealed that observed percent of falls is 24.3 and falls with major injuries at 1.7%. Review of the facility's quality report from October 2017 to December 2017 among 70 residents that had a minimum data set, which is DMDS assessment. 20 residents had a fall within the last quarter. Interview with the nurse leader, who was the unit manager on root cause analysis, stated that falls happened during the first 72 hours post-admission. Staff awareness and safety is an opportunity, and culture change is needed to take falls seriously. Adequate staffing is also critical on patient safety. Interview with the director of staff developer, role of the CNA in fall prevention. He stated that training includes knowledge of basic interventions, including orienting patient to environment, call light placement, call light within reach, personal items within reach, use of appropriate footwear, use of glasses, hearing aids in an uncluttered environment, and avoiding trip hazards. Interview with human resources also on hiring personnel. She stated that staff are hired depending on qualifications and experiences as required on the job descriptions. She said that she also takes consideration on their experiences in skilled nursing facilities with experience in handling post-acute rehab patients, patients with behaviors, and high risk for falls. Solution. So after analyzing the root cause of the falls, we have come up with these solutions and an improvement goal. Improvement goal is to reduce incidence of falls by 50%, which would approximately reduce to 5 falls a month in Unit 3. And we also need to evaluate the current organizational structure of the facility and identify primary stakeholders. Conduct a short survey of the culture of safety at the facility and fall prevention. Involve the interdisciplinary team to get their buy-in to implement the change in fall prevention program. According to Smith, to gain buy-in, give the team opportunities to co-develop the process. Identify a champion for the fall prevention program to implement the changes. Fall risk assessments are to be done for the newly admitted short-stay residents. According to Leland, falls are common events among newly admitted nursing home residents who remain in the facility for at least 30 days. More of the solution interventions also include identifying patients with frequent falls and moving them to rooms closer to nurse's station for closer monitoring and line of sight supervision. Educating the staff also on the impact of falls and patient safety, and top 3 reasons why patients are falling, including toileting, trying to get out of bed, disorientation following admission, also educating nursing with risk factors, preventing strategies, and application of fall injury statistics can improve the safety of fall prone patients. Identification of a falling star program to identify residents who are at risk for falls to increase fall awareness. Now we are on the do cycle on the solution implementation. Here are the steps to be taken to effect the change and to solve the problem. It reflects the participation of the stakeholders and analyze the effect of the solutions that will include a detailed timeline. Meeting with senior management to discuss the reason for the change and impact on patient safety by 1/5/2018. Arrange a meeting with the nurse leader who is the champion for the change and will track and trend all fall incidents on Station 3 by 1/10/2018. Schedule an education session with the Director of Staff Development, who will provide training to staff members on the importance of patient safety by preventing falls, including the appropriate interventions to address the root causes by 1/12/2018. Identify the patients who are at high risk for falls, and patients needed to be moved to rooms closer to the nurse's station with the falling star sign by 1/15/2018. Part also of the solutions are to assign lesser number of patients to CNA assigned to high-risk patients with a maximum of 6 patients, to implement fall interventions changes to address patient safety and incorporate these intervention in patients' plan of care by 1/19/2018. These interventions would include toileting before and after meals and before bedtime, get patients up in the morning and in the afternoon, offer daytime activities to confuse patients, place new admits to rooms in front of the nurse station. Next is the study cycle. Analysis. Data was collected and analyzed to determine if the solution met the goal of 5 falls a month. So here are the results. The total number of falls in Unit 3 between January 25 to February 15 was 8. Falls with 72 hours after admission were 1. Falls due to toileting issues were 4. Getting out of bed were 2. Behavior issues is 1. Staff did not anticipate and follow toileting schedule. Staff attitude not very engaged due to staffing challenges. The last phase of the PDESA cycle is ACT and next steps. So we did not meet the goal and objective 5 falls in a month on Unit 3. So the following measures will be taken based on the analysis of effectiveness of the change. The solutions will be continued to sustain the process and to continue to meet the objective. Education sessions with nursing staff will be repeated next month to reinforce the change. Fall interventions should be implemented consistently by staff. Fall champion should be retained on Unit 3 to trend and track fall incidents, follow up with human resources and staffing challenges, and PDSA cycle to start all over again with different plan to reinforce staff knowledge and reinforce staff accountability on anticipating toileting needs and administration to address staffing issues, which were barriers in change for quality management and preventing falls. Here are my references. And thank you so much for listening. Be safe, and thank you for your time.